Thank you. So now your turn to introduce the next speaker.
Okay, so of course we have our next speaker, and he is Dr. PM Gopinath. He is going to talk to us on fertility and pre-treatment of uterine fibroids and adenomyosis. He is he's the director and senior consultant of the Institute of ONG for Medical Science in India, and he has performed many cases, and he's a specialist in both hysterectomy, laparoscopy, hysteroscopy, even microsurgical tuber anastomosis. And he's also dealing with infertility and expert at the IVF. He is currently a member of the European Society of Human Reproduction and Embryology. He is also an elected member of the American Society for Reproductive Medicine, and he's a member of the International Fertility Preservation Society. He's the founder secretary, IFS Tamil Nadu branch, and he is the deputy head, the medical group of endometriosis management of the Shanghai Medical Association. Over to you, Dr. Gopinath. Is he there?
I'm here.
Oh, okay, good. Yeah, let me take over.
Okay. Can you see my slides?
Not yet.
Can you see my slides?
No, still not yet. Yes, okay, we can see now.
Fine. Thank you, chairpersons, and the societies for having invited me to share some of my views. So I'll be talking to you on pre-treatment of fibroids and adenomyosis. You know that we have started on an IVF in 1978, and then from then on about 40 years have come. Even though you will see here, the Louis Brown's has got his own child. The second generation has come. But however, our results are not very great. It has been only about 20 to 30% all through. And mainly it depends upon the age of the patient and the ovarian reserve, male factors, stage and grade of the transferable embryos, uterine environment, luteal support, and additional risk factors. So when you focus it on the uterine factors, you will see that it depends upon the size and shape of the cavity, endometrial lining, blood flow, receptivity, myometrial support, mainly presence or absence of fibroid and adenomyosis. How does this fibroid affect?
Excuse me, Dr. Gopinath, your slide is not moved.
Now, my slide is moving here for me.
No, but for me, it doesn't move.
One minute, I will stop sharing and share again.
Okay, please.
Is it visible now?
Yes, yes.
Yeah, this is infertility and myoma. It is very commonly seen in IVF patients because there is a delay in childbearing when fibroids become more common. Also, the age decreases the fertility. There is some encroachment of the tubal ostium, distortion of the cavity, vascular changes, interfere in the rhythmic contractions, impaired implantation, abnormal endometrial maturation, and alteration in oxytocinase activity. So when you see the normal uterine cavity, there is something like called cavules in the host myometrium. So this number of cavules are decreased when there is a fibroid. Because of the structural changes, there is an increase in intracellular calcium. If there is an increase in intracellular calcium, it produces myometrial irritability. that results in the disruption of the rhythmic contraction of the junctional zone, which is very responsible for implantation there. What about the subendometrial tumors? They're causing the erosion, subsequent inflammation, and they disrupt the endometrial blood flow and affects nidation and subsequent early embryo. If you look at this review by Jacques Donis in 2004, he has seen the impact of myoma on infertility when it is distorting the cavity and then there is no distortion. You will see in this study, there is a distinct reduction in the pregnancy rates in a patient who has got the distortion of the cavity with his fibroids there. And this is again another important PRIT study, which consists of about 3 prospective and 8 retrospective controlled studies, where they concluded subserosal fibroids do not affect the fertility or spontaneous abortion rate. Submucous fibroid lower the fertility rate, and myomectomy enhances the rate of conception and live birth. Intramural myoma with or without of the cavity may have caused detrimental effect on reaching the viability of this thing. Effect of myomectomy is not clear. And if you look at the submucous fibroid, when it compared to the control, the clinical pregnancy rate comes from 30 to 14%, and the spontaneous abortion rate goes from 21% to 46%. So that means definitely it has got an impact. And the effect of myoma, when you see an intramural myoma, there are conflicting reports. Some of the papers saying that it negatively affects IVF results, and some of the papers says that it do not affect the IVF results. So in total, when you just see the implantation rate, if it is there from there, it stops from about 20.2 to 11.2, and pregnancy rate drops from 34.1 to 23. Ongoing pregnancy is dropped from 28 to 15%. So a large intramural myoma negatively affects the pregnancy outcome, particularly when it is more than 5 centimeters. And again, when it is larger than 5 centimeters, it definitely has got an impact. But that doesn't mean you cannot go on performing this myomectomy in a woman who is not coming for an IVF, because by doing that, there will be an excessive adhesion formations there. What about the fibroid, which is less than 5 centimeters? Should be, you have to disregard it. Do we operate before IVF? Should we operate after IVF failure? And if yes, for after how many failures? Should we operate before any infertility treatment? Should the decision be influenced according to the cost of IVF in different countries? These are all the questions which comes into the mind when you're dealing with a borderline fibroid. But however, when you look at the studies, they say that there is no difference in implantation rates in pregnancy when it is smaller than 5 centimeters. And another publication, fertility study, says no effect in pregnancy rate and there is no miscarriage rates. So the small fibroids, when it is less than 5 centimeters, you will see that in a control, it is about 32.9 against the pregnancy rate of around 29 in another study here. So overall, when you take an ART, the ongoing pregnancy and the live birth are reduced in an ART by 40% in the successive cycle. So that means if you want to improve your IVF rates, you have to go in for an intramural fibroid removal in whichever form which is comfortable to you before you plan for assisted reproduction. Here again, this study, you will see that the results of clinical pregnancy rate in a patients without myoma, it is 41%, and with myoma, it is about 34%. You look at the number of abortions, it is about 18.9% without myoma, whereas if myoma is there, it goes as high as about 40%. So this is again looking at the number of fibroids. If you see the second column, it is less than 3 myomas. Third column is more than 3 myomas. You will see that the number of abortions is about 34.3% if it is less than 3, whereas when it is more than 3, it goes as high as about 60%. This again shows the importance of treating myoma before you go for a IVF. You look at the pregnancy rate after an IVF here in an intramural. So in different studies, they have just compared it with the control. It is much less than that. All this, the pregnancy rate is much less than the control. However, you look at the miscarriage rate is much higher than the control in all the studies. So this is to just say, you have to go through some form of a treatment before ART. And then what about the implications of a myomectomy? This is a Dubison trial which just says the importance of adhesions and then adnexal adhesions here is very high, both with laparoscopy and laparotomy. This is a region where we just contemplate on the thing head. But now coming to the problems in the management, one is the cost of the treatment of fibroids and adenomyosis adds. And there are some aftermaths of the treatment, scarring and then poor vascularity, time taken to heal and be ready for the embryo transfer, patient's emotional stress, results of the embryo transfer after the treatment of a fibroid and adenomyosis. All this are the problems with this. What about the adenomyoma? Most commonly seen in IVF patients because of the delay, and also there is an increase in age. So this is the junctional between the outer and inner. This is the area where we see the junctional zone. This is very important because it has got a series of changes, and it is a functional important in the entity in reproduction. Oncogenetically, it is related to the endometrium. Cyclical changes here has been affected, and the role of gamete transport and implantation takes place here. Early changes from time of implantation is very important here, and decastulation and the trophoblastic invasion takes place in this particular junction. If there is a defective transformation of this junctional zone spiral arteries in the spectrum, it can result in any of the complications there. So junctional zone by itself is very important, and it exposes the embryos to a higher junctional zone activity as a consequence of high hormonal levels due to the controlled ovarian hyperstimulation, uterine manipulations during the IVT. So if there is an abnormality of the junctional zone as a result of adenomyosis, the implantation definitely comes down. This is to highlight the various junctional zones. And this is what we mean by the endometriosis. This is a normal junctional zone, whereas it is uniformly higher where it is a global adenomyosis, when there is a focal adenomyosis in only one place. This is how it looks in an MRI and all these areas there. On a transvaginal ultrasound, it's an asymptomatic uterine enlargement, and it is a globular appearing uterus. Between the transvaginal and MRI, MRI is more sensitive and then gives you an accurate diagnosis there. What happens when you do an ART in an adenomyosis? Number one, few follicles and poor corpus luteum, M2 oocytes with scattered chromosomes here, cytoplasmic fragmentation, formation of a pseudopronuclei, and spontaneous oocyte activation occurs, reduced fertilization and abnormal nucleoli, delayed and arrested embryo and cleavage, no microtubules in the blastocyst. So, and what happens when there is an adenomyosis in an oocyte donation program? You will see here, when it has been compared with the low responders, it is again poorer, and then you can just see the term pregnancy rate is about 22 when compared to 33 as per the presentation in an rate. And here there is another Bernhardt analysis here. It says significantly lower pregnancy rate when you compare to that of a tubal factor in infertility in the case of adenomyosis. Again, the same way, when you look at the endometriosis, 3 and 4 had a much lower pregnancy rate when compared to 1 and 2. So implantation in ART is mainly on the embryo quality, transfer efficiency, and endometrial receptivity. Whereas in an adenomyosis, the endometrial receptivity is completely lost there. When to offer IVF? Does it affect the IVF outcome? Is medical treatment is useful? Should ICSI always be done? If the surgery is needed, when to offer and which technique is the most crucial decisions here. We all know we have just started with the medical, surgical, combined medical and surgical, came to the ablation, then MRI focus. My previous speaker has beautifully put up the difference between the MRI focused and an HIFU ultrasound, and then brought out all the evidences there. Meta-analysis says that there is absolutely no great improvement in the medical management before the RCT. This is an historical study from the surgeries from Osada, where not many Osadas are arising in the universe today to handle this. And you know, whenever you do a surgery on an adenomyotic, you will have a lot of difficulty in covering it when you do it, both in a laparoscopy and also open surgery. It is something like cutting a guava fruit and then enclosing both the structures together. It will be really difficult and challenging there. MRI has evolved. It was been for, but now somehow or other, the instruments are not being that common in my place, where I had a training in MRI focused ultrasound. We were doing it. Then now it has just come to the HIFU, where it gives you a lot. The professor, who with all his handicap, has beautifully put out all the points for a HIFU and why he mentioned it. It has to be just covered at the current day, even though we have all the other adjuncts here. And if you are going to go in for an ART, both for prolapse and also for both for the fibroids and adenomyosis, you have to think in terms of that. You know, even after an adenomyosis, if she becomes pregnant, there are a lot of issues, like, you know, it is highly risky. There will be miscarriages, and you should avoid sharp curettings there because it enhances. But however, sharp curetting and non-pregnant does not enhance this. To conclude, fibroid and adenomyosis are enigma to the ART personnel. There are definite evidence to say that they decrease the pregnancy rate and live birth. The miscarriage rate is higher than the control. Their managements are confusing and invasive. There is a need for a novel, minimal invasive, cost-effective procedure to tackle them and improve the pregnancy rates in an ART. Probably, I think we have arrived at an answer with way of IVF before an HIFU has to be done. Thank you very much for your patient listening.
So thank you very much, Dr. Gopinath. So I'd like to ask if anybody has any questions to ask. You can write it down on the chat. If not, then I'll first start off with my own question. Where do you see the place of HIFU in the management of infertility? Since you say that you have had training, but you haven't done any cases so far, and what is your prediction for the role of HIFU versus so-called standard laparoscopic surgery?
Fine. See, basically, I was a open surgeon, then switched over to laparoscopic surgeon, and then did an MRI focus, and then had a training. So I can go through the pass through the generation. If you see a fibroid or an adenomyosis in a patient, young patient who is coming for infertility, I would, if they are going for an ART, I will stimulate them, pick out the oocytes, create the embryo, preserve them, then take them for an HIFU, and then after the reduction, and then probably after 3 months to 6 months, I will go for a transfer. This will be my answer to your question, sir.
What if they haven't come for fertility yet, but they say that we are thinking about trying? So what would be the role then, if you see such a couple?
Yeah, if you're asking about a non-ART couple with infertility coming with the fibroid, as we have mentioned it, the size, number, location plays a very important role. Based on that, If I have an option to do an HIFU, I will very easily just go for an HIFU and then after 3 months plan for the treatment directly.
Okay, thank you very much.
Thank you.
Thank you.